Wow, what an amazing way to kick us off. Thank you, Trevor and Amber. We're now going to be moving on to our first panel session. J'aimerais inviter Patrice Gilbert de Pédale Santé de venir pour faire une introduction. Merci.
Good morning, bonjour à tous. I'm from Montreal, not from Saskatchewan, so it is a difficult moment for me. Congrats to Saskatchewan, well deserved. It's a real privilege to be here with you today among leaders, patients. It was very moving, and innovators who are shaping the future of connected healthcare in Canada and around the world. Today's session, Global Lessons in Interoperability, could not be more timely. We have with us voices from Portugal, Australia, and the Netherlands. Because healthcare is ultimately about people. At Pedal, we see integration capabilities not only as technical milestone, but as a human enable. Something that connects people as much as it connects systems. Our patient hubs brings together hospitals, clinics, health authority to better align medical capacity and patient demand in real time. Whether it's helping emergency departments redirect patients to primary care or coordinating clinical schedules across departments and sites, we see every connection as one more step toward a more responsive health system. It's about creating visibility, trust, and coordination, so that every clinician, every patient, every province in Canada can benefit from the collective intelligence of the system. And that's why partnerships matter. Organizations like Canada Health Infoway play a critical role in setting the national standards and governance frameworks that make this vision possible. Their leadership allows innovation from across the country, so partners like Pedal can deploy at scale and deliver lasting impact, connecting millions of Canadians. Altogether, we have the expertise, the technology, and above all, the shared purpose to build a truly connected healthcare ecosystem. A system that learns, adapts, and delivers value to every person it serves. Today, we're so privileged to hear from 4 outstanding leaders who embody what global interoperability looks like in action. First, from Portugal, Cátia Pinto, Head of Global Digital Health at the MOH. From Australia, Peter Aloran, Chief Officer at the Australian Digital Aid Agency. And from the Netherlands, Bianca Rouwenhorst, Chief Information Officer at the Ministry of Health, and Urko Koemens, Digital Health Policy Coordinator. To moderate this discussion, we're joined by Abby Kalra, EVP of Connected Care at Canada Health Infoway. Please enjoy the discussion.
Good morning. Welcome back. Hope yesterday was an enriching day for all of you. It was so fascinating to see those hallway conversations, during the networking break, engaging conversations, one-on-one, whether it was business discussion or whether it was critiquing some of the proposals or work that we have put forward yesterday. But it was really great to see that engagement going around. And the buzz. So we hope, as Infoway team, we have served the purpose so far of engaging you all through these very important discussions. And what's coming up next is another very important discussion. Learning some lessons around the globe. We're privileged today to have some of our global leaders present in this room. And we're hosting Global Digital Health Partnership. So let's learn a little bit about that global forum and what is the purpose of GDHP Summit. Before I do that, I want to remind you, we will have a Q&A session, but we'll make sure that we leave some Q&A sessions for you, some time for you to ask the panelists some questions. So let's dive into the GDHP. So in order to give you more detail about the sense of purpose of GDHP, what does it do, what is really our objective, how does it function, I would like to invite Bianca Rovenhurst to the stage. She's going to give us an overview of GDHP, and then we'll come back. Thank you.
Thank you, and good morning, everyone. C'est un honneur et un plaisir de m'adresser à vous ce matin, ici dans le magnifique Quebec. Thank you to our gracious hosts for showing us the deep roots of the Quebec culture, and also to our host at Canada Health Infoway for bringing together this remarkable community of digital health leaders. It's a pleasure to be here in a room that feels very familiar. Not because we meet here often, but because we share the same daily reality. How to turn digital possibilities into trusted data, smarter policy, and more, better health. Even though we are from across the world, you understand exactly what our day looks like. The deadlines, the decisions, and the debates. That sense of recognition is what the Global Digital Health Partnership, or GDHP, is all about. As chair of the GDHP, I have the privilege of working with amazing colleagues from 42 countries and multilateral international health organizations, such as the World Health Organization and the Organization for Economic Collaboration and Development. The GDHP is a government-to-government collaboration to improve health for all by leveraging the opportunities of technology. It is a space where senior officials and our top experts come together to share experiences and insights. Each of us has a different context in which we have shared challenges, such as an aging population, higher and more chronic disease burden, rising costs, and workforce shortages. In this group, we find that the similarities are greater than the differences. These are the people that understand that what the role of government is and share the challenges that we face. It is them who I call first when a new digital health policy challenge lands on my desk, because they've been there. They know the tension between ambition and implementation, between innovation and safety. The GDHP is a network built on trust, a safe environment to share our achievements, but also to share our missteps, the pilots that didn't fly, the policies that met resistance, and the lessons learned the hard way. What makes the GDHP valuable is precisely this ability to pause and reflect. We are all racing ahead nationally, implementing interoperability frameworks, exploring AI in health, tackling cybersecurity, empowering citizens with data access. But in the GDHP, we take a step back and back to ask, do we understand the problem? Are we learning from each other's journeys? Within this circle of peers, countries can validate their choices and benchmark their progress. We discover patterns, common enablers, and common barriers. And by putting them on the table, we save each other time and effort. Sometimes reflection means realizing we share the same challenge. Sometimes it means finding inspiration in an entirely different approach. Having trusted peers means you don't start from zero. You can test ideas, sense-check strategies, and find reassurance that you're not alone in navigating in this complexity. Often, a 5-minute conversation with a GDHP colleague saves months of uncertainty back home. When these reflections come together, something powerful happens: convergence. Not forced alignment, but a natural coming together of ideas that makes our collective direction clearer. In this session, the panelists will share some of the best examples of that. But there's one that I would like to highlight here. Some members have national legislation to mandate electronic recording and exchange of health data. In my own country of the Netherlands, we have a law called WEGIS. Our Canadian colleagues have approached several GDHP member countries to learn about the way we regulate access, consent, interoperability standards, quality assurance, certification, and more. A lot of what they learned was applied and used as inspiration for the C72 Connected Care for Canadian Acts. Now I realize that this proposed bill has not yet completed the legislative process and that C72 is waiting to be reinstated or reintroduced, but it does show that these insights, forged in discussion among equals, feed directly into national policies. For the Netherlands, chairing the GDHP over the past 2 years has been an honor and a learning experience. We've witnessed how open dialogues between governments accelerates understanding far more efficiently than formal statements ever could. And we've seen the energy that emerges when countries realize their individual efforts are part of a larger global movement. At the end of this year, we'll hand the chair to Portugal, confident that the spirit of openness and curiosity will continue to thrive. As we look ahead, let's keep the GDHP what it was meant to be, a space to reflect, to test our ideas and move forward together. Because in digital health, progress is the straight line. It's a shared path that we illuminate for one another. So I invite you, keep the conversations open and honest. Keep the ambition high and keep building those bridges between policy and practice. As the famous Chinese proverb goes, alone we may go fast, together we go far. Mes démons sont en français. L'esprit de la collaboration règne dans cette vallée et c'est un cadre idéal pour cet événement. Merci. Thank you, and I look forward to the discussion that follows.
I would now like to invite our panel, and I'll do the introductions one more time. Jim Bloemberg, he is the Manager for Interoperability Regulation, Ministry of Health, Welfare and Sports, Netherlands. Come over, Jim. Peter O'Halloran, Chief Digital Officer at Australian Digital Health Agency. And last but not the least, Cátia Pinto, Medical Doctor and Health of Global Digital Health and International Affairs, Shared Services in Ministry of Health, Portugal. Okay, so, can you hear me okay? Yeah, we heard from Bianca. A lot of common themes are emerging, when you look at the stories around the connected care and the awareness of various legislations across the countries and how they're being leveraged to advance the patient-centric model. And I think we have benefited a great over the last few years in terms of our participation with the Global Digital Health Partnership Summit. And we have some great examples of when you think about, the International Patient Summary. 2 of our regions, Nova Scotia and New Brunswick, they are leading the charge in giving the ability to their citizens to be able to produce, to be able to generate their own patient summary and carry it on their phone. I mean, that's remarkable. right? So these are some great stories, that emerged, as part of the global collaboration. Together, we came together and produced this national standard, IPS, and that resulted into an outcome-based product, that we're currently being used in the couple of regions. So, great value benefit working together. As we move forward, let's dive into a little bit around the patient-centric theme, because Bianca touched on that. The key problem that every single jurisdiction, every single international peers are trying to solve is, how do we really enable our citizens to have a comprehensive access to their electronic health record? I think, every single survey that we have seen or read, 9 out of 10 patients, do want access to their electronic health record. They all believe, it gives them the empowerment to manage their health better and look after, even their as caregivers, look after their loved ones. So I would like to start from our peers to understand how are they advancing this and how far they have achieved their goals in terms of providing access to their citizens to their electronic health record. So perhaps we can start in this order. Cátia, if you can go first.
Yeah. Thank you, Abby, and congratulations to Canada Health Infoway for this beautiful conference, and thank you for inviting the Ministry of Health in Portugal. Indeed, in Portugal, citizen-centeredness, it's a really important part of our national health service. We make sure that our citizens are able to access their data, and we really want to make sure that data governance and data interoperability, it's actually an integral part of the daily care. We want to see it as a health service in its own right. And this means that we are building a national portal and a national app that are available to citizens free of charge at the point of use, where they can access their data regarding electronic medical records, lab results, medical images, everything that they need, and to make sure that this data can have a practical utility. And this, coupled with trust, really means that our citizens are able to trust in governments and in the way that we are creating the solutions that enable data to be used.
Fantastic. Peter, you want to go next?
Yeah, thanks, Abby. And once again, like Cátia, it's an amazing event, and thank you so much for inviting me. I've learned a huge amount and made a whole lot of new connections already. In Australia, we have what was originally called the Personally Controlled Electronic Health Record, now the My Health Record, which is, in essence, a shared summary of a patient's treatment that crosses all care settings in Australia. We've had that for nearly 15 years, and I think the original name I actually prefer because it really emphasised that it was the consumer who was front and centre. The consumer was the one who had access to the record, as did their clinicians. The consumer was the one who had the ability to control who could see it. And that really is the cornerstone of how we do interoperability in Australia. It's something that's not perfect. We've had it for 15 years. We're modernising the technology. We've seen variable take-up by clinicians, and we might discuss a bit more some of those challenges as we go through the panel. But the one thing I think that really stands out for me in interoperability in Australia is every single time we're doing something, we're doing it thinking about why we're doing it. And the amazing opening this morning from Amber and Trevor really sort of reminds me why we're doing it. It's about enabling clinicians to provide exceptional care for patients. Ensuring that healthcare is freely accessible and using digital tools to make it much more readily available is a core premise of what we do with both our My Health Record system and our broad interoperability work across our country.
Fantastic. Jim, go ahead.
Yes, thank you. And an apology to the room because you were promised someone else, but you got stuck with me. But thanks for having me here, and thank you for this wonderful venue and this the great day we had yesterday. We had a small discussion among the panel members that we should disagree amongst each other so to spice things up. Unfortunately, that first question is making it really hard because I'm going to have to agree with what's been said. So what we see in the Netherlands is you need to put the patient first in the entire idea of what you're doing. So what we had was basically a lot of individual projects which led to a lot of different points of reference for patients to get some parts of their information from our separate healthcare records, but nothing that really combined the information available, and nothing that really empowered the patient to have a good overview and be able to manage that. So that means that that meant for us that as a government you need to step in and start creating that in probably likely in the same way that Cátia has described. Something that we've done for a pension system, so that you can have an insight into how your pension funds are being managed and what that means for you. You want that in one system. You want that for your patient records as well. So that's where we're moving towards. We've created a set of standards and policies. We call it Medical Me, and which in Dutch also means, the term med also means with, so it's sort of medical me, but it's also with me. Is a set of standards and policies that creates this opportunity to centralize and put the patient first within any healthcare record system.
Great. I mean, we talked about it yesterday. We have 13 different health systems across our provinces and territories. If you look at their digital health roadmap, patient access to data always comes as the top priority. So hopefully, I think after this forum, it'll be an opportunity for some of those leaders to reach out to you and also learn some specifics, what has worked, what hasn't worked. Let's dive into a little bit out, whenever we talk about electronic access to data, health data, and whenever we talk about exchange of patients' health information across the settings, regulation always comes into play. Regulators always come into the mix. And I'm okay if you want to be provocative as well. How have you been able to balance privacy concerns, consent concerns, at the same time, putting innovation on the front, so that, they don't slow you down, but you also meet their requirements and still move forward, with the dual goal of access and exchange of patient health information. And if you can explain that maybe with a tangible example, that would be even great. You want to go first?
Yes, indeed. Privacy and trust is really something very relevant when we are talking about exchanging data. In Portugal, we ensure that we have a high level of trust around our government while being the responsible for interoperability of health data in the country by combining a mix of accountability and transparency. So we enable patients to give their consent and to follow up the use of their data. Patients are able to see who accessed their data and when and why, while at the same time, we make sure that we have high levels of privacy and security in our systems so that citizens can understand that privacy and innovation can actually go hand in hand. If our citizens and our healthcare professionals, if they believe that we can have both privacy and innovation, and that actually innovation can enable privacy in ways that we weren't able to achieve before, this can be a powerful mix that can unlock the power of health data and ensure that interoperability is a reality in our healthcare system.
Look, very similar to, I suppose, Portugal. In Australia, we have very strong legislative controls in terms of access to the information in health systems, and particularly in the My Health Record system. And we started off with an opt-in process for My Health Record. Didn't go so well. A few years later, we changed to an opt-out process, and I think we've got about 91% of Australians have a My Health Record. A lot of the work we did around that was really explaining those privacy controls so that we're really clear that patients are actually the people who are in the driving seat. They have control of who has access to their record. They can choose whether, in fact, they have a health record nationally or not. If someone has access to their record, they can see it. They can grant access to individual documents or the whole record. And we also provide those really strong sort of audit trails and security controls. And things occasionally go wrong. It's life, it's healthcare, it's IT, it happens. So what we also do is we put a huge amount of effort into cybersecurity protections. We have our My Health Record system, the back end is classified at a security level that's similar to what we do for some of our national defence things. So it really is, we put a huge amount of effort into doing that at one end. Occasionally, we've had a number of examples where clinicians have inappropriately accessed records. We don't shy away from sharing that. In fact, we publish that and it goes in our annual report, and it goes from the Office of the Australian Information Commissioner, who is the regulator who oversees access, goes in their report to our Parliament, and it's made available to everyone. In that, we go through what actually happens if there is a breach, and we've had one in the last year or two where it was actually uncovered by a healthcare consumer seeing that a clinician had accessed their record when they weren't being treated by that clinician. And so it was actually the consumer who triggered the investigation. If there's an inappropriate access to a record, under our legislation, potentially it's a criminal offence. So we talk to patients about what actually goes wrong, what happens if someone does actually access it inappropriately. And I know of very few clinicians who get bored and just want to go surfing through somebody's record. Who has the spare time as a clinician to sit there and do that? But occasionally there's one or two who do something inappropriate for whatever reason. And so we explain to consumers that it's a criminal offence, they can and they will be prosecuted. Secondly, normally it's a grounds for being deregistered as a clinician, so their entire professional and everything they've worked for is taken away. And thirdly, it's almost guaranteed their employer will fire them. And so when you run through those consequences with consumers, they suddenly have a very different focus of, oh, okay, so you actually take it quite seriously. Yes, we do. And I think having that trust, having that engagement with that community to say, this is what we do, we believe in it strongly, and we will protect your information. Here are some of the controls, and here are tangible examples where we've enforced it, really makes all the difference.
Right.
Jim, over to you. Privacy is a two-edged sword, really. So on the one hand, you need to secure the information. You need to put privacy by design as a part of your policies and how you set up the systems. So you need to start building them from within that vision. You need strong frameworks. So in Europe, we of course we have the GDPR, we have network information security, extra guidelines, rules. What are they called? We have the critical entities resilience guidelines from Europe. So we have a lot of those. And I think those are essential to create the right cybersecurity setting. You also need to educate all the people working with the data, because the biggest problems we have with data leaks or data going where they shouldn't go is not by the technical errors, but it's by the way people use it and the mistakes they make. A few weeks ago, we had some people in the Netherlands fired from the hospital because they were looking into patient data that they shouldn't have been. So logging is a part of that process. We are shifting from having a physical paper file in a cabinet that you can lock, and that the person who wrote all that down is actually able to make sure that it only travels to those people he or she wants that information to see. We are progressing from that to a digital space where the information is available to actually anyone who we make access to, and this is what we want. We want that data to flow with the patient where the patient is going, but that is a paradigm shift. It really means that you have to focus on then how do you make sure that only those access it who should? So it's a high penalty, high trust that you're working towards. So then we get to the other part, which is about trust. That's the other part of the sword. The more you talk about privacy, the more you can make people skittish. And I mean, to quote Monty Python once again, sorry, Herco, they did a sketch about the John Cleese sitting as a pilot in the front of the airplane, and he grabs the microphone and he simply says, "Ladies and gentlemen, there is no need for alarm." And you can, and he becomes silent, and he waits a few minutes, and then he grabs the mic and he says, "The wings are not on fire." Wait. You can imagine what happens if you do that in a plane. So you're trying to create an atmosphere of trust and comfort and safety, but the more you talk about that, the more skittish people get. So trust is really a feeling, and it's not just about giving people control, because if you would put an emergency button in every seat in the airplane so you can stop now, I wouldn't feel safer. I'd feel safe knowing that the pilot there is well trained, the aircraft is well maintained, and that there's lots of people who do that. And I don't want to be bothered by that. So trust is also about that. How do you create that feeling of safety? And you do it by implementing a lot of things that, without actually having to make it a big deal. I hope I make sense when I say.
Makes total sense, yes. You got a good chuckle out there as well. It says, privacy by design, consent by design. I think it's a very important concept that you brought in your conversation. Because often what happens is privacy and consent built into the system is thought afterwards, which is one of the reasons I think, we often stay in that zone where we have the legislations, we have the privacy laws, but we don't know how they're being demonstrated into the system. So I think by design, it's a very important concept, to be built into our work. Let's move from policy to practice. I know, through the last 2-3 years, working with you all have a long 3, 5, 10-year roadmap for connected care within your own jurisdictions. What's the one single most important lever that you think has actually helped you advance that transformation when it comes to connected care? Be it policy, be it funding, be it change management. Just your thoughts on those. Cátia, do you want to start?
Yeah, for us, but let's see if somehow we can disagree in this one. But for us in Portugal, the big lever was the creation of a national digital health agency 15 years ago to ensure that we have a central governance but shared ownership of our health information ecosystem. So with the creation of this agency that was entrusted with the governance, the regulation, the development, and the deployment, and so in full to have a strategy, a defined strategy for health information ecosystem was really a key point in our interoperability road. Of course, the digital health transformation of our health system was much older, but the centralization and the establishment of a good governance at the central level was a cornerstone. And within this governance is really the culture of trust as well. So we need to ensure our citizens that they can trust us as safeguard for their data. And this is built, this is a process, it's not a project, this is a process that is entailed in good governance, and digital health is no different. So we really want to make sure that we are as good in developing and deploying technology as in regulation.
Great, thank you. Peter?
So a different answer from Australia, but I love what Portugal's done, and it resonates with what we've seen in Australia. The biggest change for us has actually been legislation or regulation. So I touched on we'd had our My Health Record system for about 15 years. Earlier this year, we had new legislation passed by our Parliament, which is called Share by Default. In essence, what that legislation does is it mandates that clinicians must share information with their healthcare consumers through the My Health Record system, except either if the consumer says don't do it, or if there's a very strong clinical reason why it's inappropriate and unsafe. And we can all think of a very small number of examples where that's the case. That initially is applied to pathology and radiology only, and it will, over the next few years, apply across the health system. What that has done is actually really take on board the views from consumers, which is they wanted their health information shared, and has stopped some unfortunate commercial practices where certain diagnostic imaging and pathology services decide it wasn't in their commercial interest to share information with the patient or to make it available to all treating clinicians no matter where they were in the country. We have seen through that a massive uptake already in consumers accessing their information. We've seen a substantial rise in clinicians actually using the system and accessing that data. And when we look at, for example, a patient presenting to an emergency department, in Australia, 85% of those people who are presenting need pathology and or diagnostic imaging as part of their initial diagnosis. Often those tests have been done in the community 2 or 3 or 4 days before, but weren't available to those clinicians immediately if they present to an emergency department. Already I'm getting feedback from clinicians in emergency departments saying, this is great, we can actually see test results from something that happened 3 days ago. I didn't need to keep the patient for another hour while we did something else, or I didn't need to call someone in to do an ultrasound at 3 in the morning. And to my mind, that power of that legislation really has been the number one thing that's changed that behaviour. It's sad that we had to get to the point of having legislation, and it's probably a failure of the market in Australia. That's where we needed to get to. But what it has done is put the patient front and centre and made sure that their information is available not only to them, but to their treating clinicians wherever they are. And that's really been the game changer for us.
Okay, great. Jim?
Regulation, coming in with laws is always the last option, I think. So, as you mentioned, Peter, again, we cannot disagree. I was almost going to say a swear word, but I won't. This is probably going to be recorded, so I don't want that out there. We know it's not money. There's plenty of money going around. I looked it up. I think we have about 4% of our long-term care budget. It goes into IT and healthcare records. It's 6% of the hospital budget, so it's billions per year. So money is not the answer. I would say we know it's not regulation either, because we can draft any kind of law and then it has to be a reality. But if it's not internalized by the people who have to do it, they won't. And I know it's also not the technique, because the technique is out there, but you can devise the best technique to do it, and we still know that that won't always be the winner. Yeah, I'm older than I look. I remember when Philips made a videotape system. Sony did one, and JVC did one, and Philips made the best. Sony was, well, not far behind, and JVC made the worst one. It was called VHS. Now, you all remember that last one, don't you? So, well, maybe not all.
Digital health.
Yeah.
VHS, digital health, yes.
So back to the question. So what is the answer? I don't think it's one of those single issues. I think it's bringing them all together and mostly getting people to work together. So it's in cooperation, keeping the eye on the ball, keeping everyone shifting their focus to how do we work with electronic health records? Who are they for and why do we use them? And what is the way we want to move forward, given that we are transitioning from that paper file to information flowing? Why do we want that information flowing? That's the patient is the key to that answer. So if we can keep that part of the debate with all the parties that we need to make the entire transition work, I think that is the best aspect of making it a reality. Period.
Great. We actually got different answers, which is good. That's what we're looking for. I do have a couple of questions, but I know, we're going to run out of time. So we'll open it up to the attendees to have them ask any questions. So let's go to the attendees. Yep.
This question is primarily for Peter, but I think that's only because I'm not familiar with marginalized populations within Portugal and the Netherlands. But has Australia seen an issue with its Aboriginal population picking up the use of digital solutions at a higher rate than the rest of its population? And in the other two countries, if you have marginalized populations, the same question.
That could be about a 3-hour answer to that question. Look, we've seen a huge range of challenges, and there is a huge health equity gap for Aboriginal and Torres Strait Islander people in Australia, our Indigenous people. We see huge challenges. Has there been a higher uptake of digital health? The answer is no. A lot of the work that was done for our original system 15 years ago is actually born out of the Northern Territory in Australia, which was primarily an Indigenous population where it was built. There is a strong embracing of digital technology by Indigenous people. The challenge is things such as internet connectivity in remote communities, very similar problems I'm imagining that you have here. The joys of weather, so low Earth orbit satellites don't work particularly well for internet access when you end up with sort of monsoons and torrential rains, which we get for 3, 4, 5 months a year in those types of areas. Secondly, challenges around access to devices. So increasingly we're seeing digital health is being delivered through apps. Often in those remote communities, a mobile phone or a cell phone is being passed around 5, 10, 15, 20 different community members, and so an app-based process does not work. So is it something we're doing well? Not nearly as well as we should be. We have specific programs where we're looking at where we're working across our government to get better, reliable and hopefully free internet access into those communities. We're also ensuring that whatever we do on an app can also be done on a web browser so that hopefully it takes those challenges away. And we're working with local elders to really try and understand how best we can work with their communities to serve their needs. But at the moment, we have a lot more work to do still.
Yeah, so in Portugal, digital services uptake, it's also a challenge as we want to make sure that the universal access to care, it's still maintained in the digital world. We try to make sure that we center our systems in user experience, have strong criteria for accessibility, and we couple the deployment of digital services with local administration services that can mediate for citizens, for special population citizens that are less able to use our services. We really want to make sure that they have meaningful alternatives that will not prevent them from using the services. But overall, it's a process of continuous evaluation and measurement, continuous refinement of our systems to make sure that they are suitable for everyone and that we really don't leave anyone behind when moving to the digital world in healthcare.
Thank you. Yes, we have someone there. Go ahead.
Okay, thank you. I'm really trying to think of something to start a little brawl up there. So I'm going to give you a question that I think might do it. Artificial intelligence. What impact is it having overall on your environments? And is it helping or hurting interoperability?
I think the impact could be huge. I think we all feel that it could be. Again, this is the question is how do you create that impact without the downsides that we also see? So AI, you can see the large language model as a sort of you trained your dog to sound like a human. Would you then fire your physician and put in the dog? No, even though it sounds somewhat like a human. But yeah, I mean, let's be real. Then again, AI can probably do a better job at assessing X-ray pictures. And that is already now, and it can progress a lot from there. It can, I think what we've seen with what Scribe can do is monumental. It can really take away a lot of the administrative burden, and it can also do stuff that, well, we humans aren't always as good at it. It can be much more polite than we can. And it can help translate a lot of the medical text toward patient-friendly terms that they can understand, which is also very much needed and necessary. So I think the question is, how do you make that transition? How do you make that progress, that way forward? And I think that everyone is looking for the right answer to that. And I think that's somewhat of a wicked problem. It has many dimensions that you need to put together. So again, here it's finding the right people with the right knowledge to together see how you can make that transition and put AI to work.
So one of the things we're seeing in Australia is AI scribes in primary care, like what we call general practitioners, family physicians, however you want to term them, has been a huge adoption of AI, relatively uncontrolled, relatively unregulated, but it's been a great success so far. Some concerns and things are being corrected now. What we're looking at in Australia, though, I think is also how do we ensure that those large language models can actually operate safely? And so one of the key things we're really focusing on now is how do we standardise our data to ensure that you don't end up with the traditional garbage in, garbage out, which is what we see in almost every other system whenever we've digitised in the past. And so what we're doing is we've got a relentless drive around trying to adopt sort of standardised terminology and nomenclature and global standards to ensure that the data is of a high quality, so that it's when it's feeding into these large language models, it's actually safe and reliable in that respect. But the final part is, in Australia, you always want a human in the loop. We haven't yet seen that for all of our AI adoption. I think that's a real challenge for us at the moment.
Are you good, or you want to add?
I just can finalize with this EU perspective, where we are both trying to connect. We regulated AI, we regulated medical devices, and my current perspective is that we are connecting the regulation with the implementation. So beyond the hype, I think, as Peter was saying, we are still not there to reaching the full potential of AI in healthcare, but I believe that the road that we have ahead, it's one that will actually enable it. We are truly concerned with making sure that we deploy AI responsibly.
Thank you. Lee, go ahead.
Thanks, Abby, and I know we're short on time. So Lee Burry with the province of New Brunswick. And I guess for me, kind of from that viewpoint is where my question comes, province of New Brunswick. And when we look at our provinces and territories throughout Canada, privacy is really regulated at a provincial level. Whereas I'm envious of, I think, a number of you, and that a lot of it, if I understand, is regulated at a national level. Just wondering if you could speak briefly to, when you look at your respective districts, your provinces, your states, how the conversation has evolved over the years there. Because if we look at things here in Canada as an example, and we look at privacy, and a few of us were having a conversation last evening around access to health records for minors, and who should have access to what, and to what extent the parents need to be involved, et cetera. I'm just curious if you've ever seen any of those conversations kind of pop up over the last number of years, and how you might navigate that conversation at a national level with your district, provincial, or state partners.
Let's go first.
Okay, so yes, in the Netherlands we have a national system, and which is actually based on a European system. So perhaps we could reflect on this from the European GDPR, in which, of course, we have 27 states. And those are actually quite different. So this is something that we do see, where in the more Nordic countries, it's very normal for the government to be very much involved in healthcare and have a government-controlled healthcare system, and where the electronic healthcare records are also government-controlled. Then you get to Netherlands, and our population, well, they would scream if they heard that the government has anything to do with their healthcare records or their bank material. So in that aspect, we are very different. And this is something we have to navigate. So how do we make sure that we build on the trust that we want, that we can have the policies and implement them from a government perspective, knowing that our population will not want us to be in control. So that is something we have to take into account, which is why for us it's so important to have that cooperation and collaboration with all the field partners.
Australia, like Canada, is a federation, and in a former life I was the Chief Information Officer for one of our territories for health, and so was responsible for the legislation that we also had at a territory level for health records, and we had a wonderful piece of legislation that was from 1997, so very dated. There are challenges where our legislation conflicts at a state or territory level and at a national level. That's something we're continuing to work through. Long term, I think the only option is to harmonise that legislation or repeal the legislation in states and territories. But that's probably, having done that once or twice before my career, a 20-year journey to get to that point. Some of the biggest challenges for us in differences in legislation is about at what point in time do children's records no longer be given access to their parents unless the child has consented. At a national level, we generally implement that at 14, just for various things, and it deals with pregnancies and sexually transmitted infections and those things, where it starts to get to a point where the child has sufficient maturity to make a decision, but at the same time trying to ensure that parents still have access until that point. Some of our legislation in states and territories makes that 16 or 18, and so that's an active challenge we're working through, and it's safe to say our healthcare consumers across Australia are not united in their views on where that best point sits, and I've sat through many workshops debating that with many people. But moving to that harmonised legislation is where we need to get to in Australia, and that's what we're slowly walking towards now, but it is a long journey.
Yes, just to finalize that, so Portugal is a very small country, so I would not say that regions play a big role here in deciding this, but I can put forward European Union experience with the General Data Protection Regulation and currently the European Health Data Space Regulation. So we, at the EU level, were able to agree in this Personal Data Protection Regulation, the General Data Protection Regulation, that for years regulated the principles under which all of the EU countries should protect health data. So through the years, we realized that although the principles under which we should protect our data were defined, we did not agree how we could actually share our data between the different countries at the EU level. So the answer to overcome this was the creation of a regulation called the European Health Data Space Regulation. And within this regulation, the different countries at the EU level agreed on a set core of principles and rules that will apply when sharing health data between the different countries at the EU level. So still, we leave some margin for national authorities to decide on how they want to implement those principles. If we choose an opt-in model, an opt-out model, we decide which rules apply when we communicate data between countries, but we were able to agree on a core set of principles that is what actually enables us to share health data between the different countries at EU level. And currently, I can give you the example for Portugal. We are already connected with 15 other EU countries and exchanging our health data, medical prescriptions, electronic health records. And it is, of course, it's a work in progress. When you start sharing data between different jurisdictions, different countries, different challenges come up with different services, with different types of data, genetic data, more sensitive data. But still, I believe that identifying these core principles under which we could create a space for data, a virtual and digital space for data at the EU level, can be a good example for other regions of the world on exchanging data between different authorities, jurisdictions, or countries.
Thank you. Before we close off the session, we could go on for hours. I think there's so much to learn, from, there's so many similarities, but there are also so many uniquenesses that each of the region has. The folks will be around for the next few hours, after the session, if you want to connect with them. But before we sign off, there are a few things that I wanted to say. Not only three of them are accomplished leaders in their individual regions, running big responsible job. I have had the privilege to know them for the last few years, and I'll personally tell you, I have learned so much from your individual journeys. Professionally, it has helped me. But I think from a Canadian standpoint, I think there's so many learnings that, we have taken into Canada. And I think some of the stories that, we shared with New Brunswick, we have leapfrogged. And now we're actually sharing that learning back to the forum. So that is really the importance of the GDHP forum. So thank you for your contribution. Thank you for coming down. Thank you for sharing your lessons, with the group. I really appreciate it. So let's have a round of applause for that.
So now we're going to break out into our concurrent sessions, each offering a different perspective on accelerating progress. Like yesterday, we're going to be offering translation services. Afterwards, we're going to reconvene later for lunch at 12:05 p.m. in the main dining area, followed by more concurrent sessions and a networking break this afternoon. Enjoy your session, folks, and we'll be back together again shortly.